Thanks for listening to the Granite List.Live. Today's episode is brought to you by Connect Healthcare Collaboration, where benefits marketing meets clinical advocacy to drive effective employee engagement.
Welcome back to another episode of the Granite List.Live. I'm Leigh Dill, and I am joined by Ron Peck today. He is the Chief Legal Officer of the Phia Group and has quite an impressive bio that would probably take the entire episode to read. But Ron, I'm so excited to have you today so that we can talk about where we've been legally with healthcare, where the stepping stones that started 2 decades ago. And you're going to set us straight with some vocabulary because we're using some words wrong. And so we're going to be educated throughout this podcast today. And I'm really excited. So Ron, thanks for joining me.
Oh man, well, I don't know about education, but hopefully at least entertained, or I guess edutained if you want to combine the concepts. But yeah, it's really a pleasure to be here. You know, this is an issue that frankly I've been talking about and others have been talking about for decades. So it's not a recent problem, but it's definitely starting to bear fruit now. And what the problem is that I'm talking about, it's semantics. And it's funny. Yes, I'm an attorney. And yes, words matter in my field. But I think words matter everywhere because how else do we communicate, right? How do people understand a concept that's important to them and their family if they don't even understand what the words mean? And it's easy, it's convenient to just throw a word out there and hope that it's going to land, right? But sometimes you don't understand the damage that you're doing. And what I'm talking about in particular, it starts with conflating the term or the phrase health care with health insurance, right? I mean, you could remember decades ago, we were talking about the cost of health care, and we passed meaningful laws, federal law, in the form of what people will call Obamacare, the Affordable Care Act, ACA, whatever you want to call it. But when you look at the law, it was primarily focused on addressing the cost of health insurance, not the cost of health care. If you need a surgery, if you need a drug for a condition that you might have, if you have a really nasty headache and you want to get it checked out, that doctor, that nurse, that pharmacist, they're providing health care. They're caring for your health. It's the word. And that costs something. They need to be paid. There's a bill for that care. That's the cost of health care. When you're talking about your premiums, your deductibles, your co-pays, right, what it costs to get health insurance, that's not the cost of health care. That's the cost of health insurance. And what's interesting, or I think the reason why this kind of misunderstanding flew under the radar for so long is because those two things are tied together. When the cost of health care goes up, the cost of health insurance goes up. And I find it interesting that most people, you, me, everybody, right? Somebody says, oh, healthcare, the cost of healthcare is such a complex issue. Nobody can solve it. But if I ask you, like, change health insurance, swap it out and add auto insurance, right? And I don't care if you've got a caveman or a lizard or someone wearing a bib or whatever your auto insurance is, I don't care. If I were to ask you, you have a reliable mid-size sedan, $40,000, $50,000 value, right? It gets you from point A to point B, good gas mileage, and you purchase auto insurance for this car. You expect it to cost a certain amount. Your premiums are going to be set based on where you live, how you drive, have you had past accidents, right? You speed, you have a few tickets. But most importantly, the value of the car, because they're thinking as an insurance carrier, if you total this vehicle and I have to pay to replace it, what's it going to cost me as the carrier? And so they set a rate. Well, if you get rid of that car and you replace it with a Maserati or a Bentley or a Lamborghini, do you know what's going to happen to your auto insurance rates? Your premiums are going to go up. Exactly. Because the cost of what they're insuring has gone up. So, you know, we think about our healthcare and we want the best, obviously, for ourselves and everyone else. And so it's not exactly an apples to apples comparison. But you have to think about the fact that if our health care has gone from a mid-size family sedan to Maserati prices, the cost of the insurance that pays for that care is going to go up. It's insurance, just like anything else. And so understanding the difference between healthcare and health insurance, understanding how the price of one affects the price of the other, is that first sort of stepping stone in understanding why things are so expensive today.
So there's something called the No Surprises Act that I think people toss around, but they don't really know what it means. Can you educate us on how that affects our health care and health insurance?
Yeah, I love that you asked that question, because the No Surprises Act, it gets passed generally with support of both parties. It's a bipartisan effort, and they're telling people, if you get sick, if a family member gets sick and they're hospitalized, you could be bankrupt because of the cost of healthcare. Again, there it is, right? We're going to pass this law, and it's going to protect you from those costs. Well, there's two questions you should be asking, right? One, how? How does this law protect me from those costs? And two, when? When does it protect me from those costs? And those are the two really important questions I think everybody needs to ask and have answered. And fortunately for our listeners, I'm here to do so. First, it's not there to protect you against all costs of all healthcare. It's important to understand how health benefit plans are generally structured. There's a network and there's a payer, okay? And the payer can be funded different ways. You could be paying a premium and then some insurance company pays your bills, or it could be self-funded, where you're putting money into an account instead of paying premiums, you're making contributions, and that's called self-funding. But either way, there's something out there that pays the bills. That's the payer. Then there's the network. The network is not your insurance. The network is not the one paying. The network is the one that negotiates the payable rate. And often, when you want to talk about confusion, we already said people keep conflating the terms health insurance and healthcare. Here's another one. People constantly conflate the health network for the health insurance. When you walk into a doctor's office and they say, who's your insurance? And you show them your card, and they say, oh, you have Blue Cross Blue Shield, you have Aetna, you have Cigna, you have United, right? What they're doing is they're looking at the logo on the card. Well, that logo belongs to the network, not the insurance. So while you think, oh, I have Blue Cross Blue Shield insurance, what's in fact the truth is you have the Blue Cross Blue Shield network. The one who's paying the claims, it could be Blue Cross Blue Shield. You could have traditional insurance with them, so they're both the network and the payer. But it could be you're on a self-funded plan, your employer, right? It could be you work for XYZ Shoe Factory, XYZ Bakery, and they self-fund their plan. That's the insurance, not Blue Cross. It's important to understand the difference between the network and the plan. Now, these networks, when they negotiate the payable rate, they're going to different providers and they're saying, hey, look, if somebody's a member of a plan that uses our network, you're agreeing to accept your bill charges minus an in-network discount. So if you would normally charge $100,000 for this service and you're willing to take a 30% network discount, you're going to get $70,000, and you need to accept that $70,000 as payment in full, meaning you can't bill the patient for the other 30. You write off that balance. That's a network discount. And the reason a provider would do that is because, well, if I'm part of the network, patients who are my customers are going to be steered my way, right? They're looking at their booklet and they're saying, who's in network? Oh, Ron's Hospital is in network. I'll go there. So I'm getting steerage. Additionally, I'm getting paid more quickly. Like there's prompt payment, there's electric pay. There's all sorts of contractual things that they get in return for agreeing to this discount. And so it's a contractual prohibition on balance billing. But if I'm a hospital and I'm out of network, I never agreed to that discount. There is no contract. And you come and you receive services at my facility, your health plan, whoever it is, insurance carrier, self-funded plan, whatever, whoever that payer is, they're going to pay an amount that they think is fair based on their calculation. So using the same example, my service is $100,000. Your plan looks at it and they say, you know what's fair for this service? $70,000. So they cut me a check for $70,000. But because I never agreed to a discount, guess what I'm going to do? I'm going to balance bill you, the patient, the other $30,000. So when you hear politicians and people in the media talking about how healthcare is bankrupting people, sometimes they're talking about the cost of the insurance, but sometimes they're talking about these balance bills. That's what they're talking about. Someone goes out of network and they get balance billed. The No Surprises Act is a law that is specifically meant to address those balance bills when it's out of network. And further, it doesn't address all balance bills. It only addresses balance bills when they're a surprise. Now, Leigh, you're probably saying, every balance bill is a surprise to me. I thought I have insurance. Well, that's not the way the law defines it. A surprise balance bill is when you go to an in-network facility and an out-of-network provider, a specialist, performs a service. Imagine you go to a hospital and it's in-network. You did your homework. You said, oh, it's an in-network hospital. I'm safe. I'm going to get a discount. They can't balance bill me. But the anesthesiologist who was at the hospital, he's separate and he's an out-of-network provider. So he's going to balance bill you. That's a surprise. Air ambulance. If you're in a major catastrophic, knock on wood, accident, something like that, and you know, they bring in the helicopter and they lift you up, they take you to the hospital, those bills would be considered a surprise balance bill. And other emergency claims. Services that are provided in an emergency situation, if there's a balance bill, that's a surprise. That's it. That's what the surprise, No Surprises Act protects you against. In-network facility, out-of-network specialist, emergencies, and air ambulance. That's it.
I had no idea. Thank you for diving into that. I want to back up just a little bit because there was something that you said that I've always kind of had questions about, and I bet some others that are listening do too. Talking about the payer decides what is fair and reasonable to pay a bill, especially if it's out of network. Where do those amounts, where do they come from? Who's responsible for saying, well, that's a fair amount?
Yeah. Well, I don't know if you've ever seen, one of those bingo holes where they put the balls in the thing and they rotate it around and they pull them out and they go B23. Well, that's more or less what they do. They go, $100,000. No, I'm just kidding.
Yeah, that sounds right.
It's interesting because different payers have a different process or methodology that they use to calculate what's payable. And it's kind of changed over time. It's important to understand the big picture before you understand how these plans determine what is a fair or appropriate out-of-network payment. And obviously, it's important for us because if we're a patient, you want to know, if I'm going to get balance billed, why is there a balance, right? Who should I be upset with? Is it the provider for overcharging, or is it the plan for underpaying? Or maybe it's a little bit of both, right?
Right.
If you could imagine, I mentioned networks before, and I don't want to bully networks, but they could be one of the major reasons why these rates are so arbitrary and out of control. It's because, let's say you have a provider, and they charge an amount that's based on sort of market forces. No different than if I go into a grocery store and I want to buy a carton of milk. Where did that price come from? It's based on all sorts of things, right? The cost that the grocery store has to pay in order to get the milk from the farmer, right? What other people are willing to pay for the milk. How much milk is available, right? Supply and demand. And so there's all these market forces that help the grocer decide what to charge for that carton of milk. And then I, as a consumer, I walk in and I say, that to me seems like a price I'm willing to pay for the milk. I'll pay that price and I buy the milk, right? That's a very easy way to think of how things are supposed to be priced. And let's say I'm a hospital or I'm a doctor, and many, many years ago, that's the way I did it, right? I said, I'm going to put up a shingle and I'm going to provide these medical services. And if I want patients to come in and get healthcare from me instead of some other doctor, I need to charge a rate that they're willing to pay. But I also need to charge a price that I'm willing to take and still be profitable, right? And so they come up with a price and the patients say that's a fair price and they agree on this. Well, eventually networks come on the scene and they say, hey, look, I've got this value proposition that I'm going to secure these discounts. Before in my example, I used a 30% discount, so let's use that. They come in and they say, hey, doc, what you're charging, I get that it's a fair rate, but my customers demand a 30% discount. So we need you to reduce your rate by 30%. Well, the doctor says, I can't do that. I'm going to lose money, right? I'm going to go bankrupt. So how are we going to solve this? I know. I'll increase my prices by however much, 30, 40, 50%, and then I'll give you a 30% discount. Now we both win. You can go tell your customers that you got a 30% discount, and I'm still making the same amount I always was. But the problem is, what about patients who don't have that network? Now the price that they're being asked to pay just went up by however much percent. And those prices are recorded in this thing called a charge master. And if you're out of network, you're being charged that charge master rate, which everyone agrees is arbitrary and inflated. It's meant to be reduced because most people are coming in with a network discount. If you're the sucker who's walking in and paying out of network, that's why there's a balance. And that's why, for instance, that No Surprises Act that we talked about was passed, and why people are worried about these balances that seem exorbitant, because they are. So if you're a plan and the provider's out of network, you're looking at the same types of factors that the provider might have looked at back in the day before there were networks when determining what's a fair payment. You're looking at, what does it cost this provider to provide the service? What do the supplies cost? What do the drugs cost? What do the nurses and the other staff to run the business? What does that cost? What do other hospitals in the area charge for the same service? What does this hospital charge other payers for the same service? What does Medicare pay, right? These other payers, government payer, right? Medicare, Medicaid, what do they pay? And you look at all these factors and you calculate a rate that seems fair, whatever their costs are plus a percent. And it has evolved over time, like I mentioned before. Back in the day, they used to use these terms usual and customary. But what's funny is usual and customary was really just a combination of, what does this provider usually charge and what do other providers in the area usually charge? Well, if all those providers get together over a cup of coffee and say, hey, what do you guys say we all increase our rates by 500%? And they say, sure, sounds great. Well, now usual customary has gone up by 500%. So now these plans are looking at things that are more objective, like cost to charge ratios, what Medicare pays, and things like that.
So much goes into this. And the charge master, I've never heard that term before. And it's like, who owns the key to that, right? Okay, transparency. You've really gotten us to a higher level of understanding how this works. And it would seem obvious that, okay, these are the prices. These are what people are paying. This is how the rates are negotiated. But why is transparency such a hard thing for people to get? Why is it so hard to see the exact prices of things? Can you help us? Like, what rules are coming around to help things be more transparent?
Yeah, price transparency to me, it's like one of those things where it's be careful what you wish for. I remember, there was a movie or a show at one point, and some kid, he finds a genie lamp, and he awakens the genie, and he says to the genie, he says, what's your wish? He says, I want to be the best basketball player at my school. Adorable, right? And the next day he shows up to school, and suddenly no one else at the school knows how to play the game at all. Well, now he's the best basketball player, but he's still terrible. It's just everyone is even worse. And so it's one of those things where you got to be careful what you wish for. Price transparency, it seems like a no-brainer, because I've been talking about how networks and insurance on the one hand and providers on the other are kind of playing this game of pickleball. And every time they hit the ball over the net, the rates go up. I need a better discount. Well, then I need higher prices. Well, if you have higher prices, I'm going to, decide how out-of-network claims are paid without your input. Well, if you do that, I'm going to balance bill your patients. Well, if you do that, we're going to pass this law. And it's back and forth, right? And what's fascinating about price transparency is I'm going to pull back the curtain and I'm going to show all the people, all the patients, all the plan members, you, me, my family. We're going to show them what your prices are. And that's going to show you, that'll drive them down. But the difference, and I mentioned before about going and buying a carton of milk at the grocery store, right? If I'm going into a grocery store and I buy milk and there's no price tag on the milk, I take it, I bring it to the cashier, I have no idea what it costs because I've, got this magic card and they charge it. And then a month later, I get charged and it's, $300 for this carton of milk. I say, I'm never going back to that grocery store. Now, price transparency, $300. Oh, I'm never going to go there. I'm going to go to the competition. The problem is price transparency only matters when it's my money. And when I know it's my money, as the consumer of the good, I have to make a cost-benefit analysis because I'm the one paying that price. That's issue number one. Issue number two, I need to know more than just the price. I need to know about the quality as well. It's so funny, Leigh, when I go on the road and I'll give a speech and I talk about, the pros and cons of price transparency, I put up a slide and I took it off the internet, right? And it's these 3 televisions, 1, 2, 3, and I list the price and that's it. And one of the televisions is $2,000, one is, $1,500 and one is $1,000. And I ask the crowd, I say, which television is the best one on the slide? And most people, they point at the $2,000 TV and they say, well, that one must be the best one because it's the most expensive, right? I mean, your parents told you get what you pay for, right? You've heard that before. So they say it must be the 2,000. Then I go to the next slide and suddenly user ratings pop up next to the price. And the $2,000 TV has 1 out of 5 stars. The next one down has 5 out of 5 and the next one maybe has a 4. Now I say, which is the best TV? They say the second one. So there's this thing where people, and it's a psychological phenomenon, it's been studied, it's called the price quality heuristic, where if people don't have other data, their default is to assume that the higher the price, the better the quality. But you can cancel that out with more information. So if you focus only on price transparency, let's say I have a self-funded plan. I'm an employer, I'm paying for my employees' health benefits, all the other employees, they're pooling their money too. So obviously it benefits us directly, not some insurance company, right? Me and my employees benefit directly if you make intelligent healthcare decisions. And I invest in price transparency. And let's say, again, knock on wood, Leigh, I hope this isn't true, but let's say you need to get in some sort of surgery, right? Like on your shoulder. And you've been involved in too much boxing, you join one of those clubs and you've been boxing and now you're starting to have some pain in your shoulder and you have to go have surgery on your shoulder.
Yeah.
And you're scheduled to go get this procedure at one of 2 hospitals in your area. And thanks to price transparency, you go online and you look and the hospital you're going to is less expensive than the other one. You say, thank God for price transparency. I'm going to cancel my appointment and go to the more expensive hospital because you deserve the best, right?
I want the best outcomes. So that matters too.
Now, little do you know, the reason the other hospital charges more is because they're paying attorneys for all their malpractice lawsuits because they keep hurting people and killing people, right? But you don't know that.
Right, yeah.
Right? Because it's price transparency, not quality transparency. So it's important to do more than just give price transparency. You need people to understand that price doesn't always equal quality. So it's one part of the battle. Now, the other thing I mentioned is nobody cares when it's not their money, right? I said, I go buy that $300 carton of milk. If I'm the one who's paying that bill, I'm not going back to that grocery store anymore. But guess what? If I've got some billionaire's credit card, I don't care what it costs because it's not my money, right? So one of the other issues that we're dealing with is that people don't understand how insurance works in the first place. They think I pay a premium, now somebody else pays the bill. What they don't understand is that if you continue to spend the insurance carrier or your health plan's money on excessive, too costly, exorbitant prices, rates, when you don't have to, that insurance is going to raise your premiums next year. They're going to increase your copays. They're going to increase your deductibles. And so that cost does ultimately come around and hurt you. So if you think, that's what insurance is for, they're going to pay the bill, eventually you pay and I pay. And it always makes me laugh. I started the conversation by comparing it to auto insurance. Leigh, I'm sure you know the example. Somebody has a minor fender bender and they say, hey, let's not tell the insurance, let me just cut you a check. That's because they're thinking, if my insurance pays for this, I'm going to end up paying for it plus.
Right.
Why don't people think that way with health insurance?
Right. So what do we do about it? What do employers do about it? What do individuals do about it? Educate us there so we can be better consumers of healthcare.
There's nothing we can do about it. We're doomed. No, I'm just kidding. Our company, the Phia Group, obviously we deal with this kind of stuff all the time. We provide consulting services and cost containment services for employers and administrators and insurance carriers to try and improve the quality of the care while reducing the cost. Everything that we teach and share, we do for our own health plan. And I can tell you, our health plan, our rates don't go up. In the last year, it went up something like 5% for administrative fees compared to, you're hearing 20%, 30% going up. People can't afford insurance anymore.
Yeah.
Employees who are full-time employees who have been on the plan for 5 or more years, they don't pay any premium. There's no contribution at all. No copays, no deductibles. It's free. Free. How? It's about educating people. What blows me away is that what we're talking about today, most people don't understand this. If people understood it, oh, you're saying I could pick and choose my provider? Oh, you're saying that the less expensive provider might actually be better? Oh, you're saying that this money will eventually come out of my pocket one way or the other? People start to make informed decisions. I can give you an example. I myself, and I mentioned your shoulder, I actually have a shoulder injury. I'm sharing PHI, right? Am I violating HIPAA? So I have a shoulder injury and I needed to get an MRI. My primary care physician, he looked at it, he said, yeah, you need to go get an MRI. We need to figure out what's going on in there. And he says, oh, contact this nearby hospital. They're part of the network. They're part of the health system that he's a part of, right? It's not his fault. He's been told if someone needs an MRI, you send them to this facility. I contact this hospital to get an appointment scheduled. And they say, all right, our scheduling office will get back to you and we'll set up an appointment. Well, in the meantime, there's an independent, freestanding MRI facility right down the road from my house. And so I asked my doctor, I say, hey, look, can I go there? If they can see me faster, can I just go there instead? He goes, yeah, I don't care. It's the same film, right? It's the same pictures. I don't care. I call them. They schedule the appointment right away. They see me the next day. I get the MRI done. We identify the issue and we start treating the problem before the hospital ever calls me back to set up an appointment.
Amazing.
And the kicker, this freestanding facility costs maybe 10, 20% of what the hospital would have charged because it's not a hospital. There's no facility fees. So knowing that you can ask the doctor, hey, instead of going to the hospital, can I go here? Hey, I've heard this is less expensive. Now, it's not all on the consumer. It's not all on the patient. Our people do enough. As an employer, the onus is on us to educate them.
Yeah.
We as an employer have a meeting every year with our people, with our plan members, with our employees, and we explain how health benefits work, how health insurance works, how healthcare works, and we've done the research for them. We'll tell them of these 5 hospitals in our metropolitan area, these 3 have the best outcomes, and of those 3, these 2 charge the least more often than not. So if you go to one of these, you get 10% of the savings. If you deliver a baby at one of those hospitals, we'll pay for your diapers and wipes for a year. You need to educate and you need to incentivize. And when you do that, people care. Because now, instead of thinking, it's somebody else's money, why should I care?
What's in it for me?
Exactly. There's a carrot and a stick.
Yeah, really fascinating. Ron, this has been such an informative conversation. I so appreciate you being here with me today. If anybody is interested in getting in touch with you or learning more about the Phia Group, where should we tell them to go?
We're all over the place. You could look us up on LinkedIn. We're writing articles. We attend all the events. But the best place to go is our website. It's PHIA Group.com. PHIAgroup.com. Come check us out.
And I know there's so much more that we could have gone over, so we might have to have a round 2 sometime. But Ron, thanks again for joining me on another episode of the Granite List.Live.
Thank you for listening to this episode of the Granite List.Live. Access our entire library by visiting your favorite podcast venue or subscribe on our site, thegranitelist.live.